I declined an intro this morning, so I think most people here know who I am. I'm Caroline Cox. I'm a urogynecologist here in our department. And this morning I'm going to talk to you and try to make an evidence-based case for liberalizing your post-operative restriction. So this applies to anyone who does surgery, ever. So I have no disclosures. And our learning objectives for today are first to illustrate the patient perspective on post-operative activity restrictions. Then we're going to compare the current post-op activity restrictions among the surgeons in our department. We'll go through and evaluate the evidence for post-operative activity restrictions that exist. And then I hope by the end of this talk, you'll be able to develop your own evidence-based post-op activity restrictions for your own discharge instructions. And I'm really hoping to have time for us to discuss at the end and hear some thoughts. What time does this end? Just so I stay on time. 8. Okay. So we're going to talk about restrictions to lifting, driving, when to return to work, when to return to intercourse, and submersion in water, and talk about that in regard to C-section, straight laparoscopies, vaginal surgery, and surgeries including hysterectomy. We'll go through all of it. So I'm going to start with some stories to illustrate patient perspective, namely my patient perspective. So the first time I had surgery, I was a college student. I was 19 years old and I broke my leg. And the next morning ended up with all this lovely hardware in my ankle. And it hurt a lot. That's mostly what I remember from this surgery, is that it was very, very painful. The restrictions I was given after surgery, I actually was able to go back in my MyChart from many years ago and find them. So they specifically said the patient's activity level will be elevate extremity, no weight bearing on left lower extremity, elevate left lower extremity, may return to work after approved by MD, and should not drive. So what did I do? Well, I pretty much followed the beginning. I was not weight bearing on that leg. I had this giant cast on it and it hurt a lot. I did elevate my leg absolutely anytime I could, because when it swelled, it hurt really badly against that cast, including on an airplane. Not easy to elevate your cast leg on an airplane. I didn't work. I was in college, but I certainly returned to college immediately. And I wasn't driving on my college campus, but when I went home for spring break, I did find a way to drive with that giant cast on my leg. And my mother was very unhappy about that. But essentially, I did what I did, mostly limited by my pain and how I felt. So the next time I had surgery, I was a medical student. And my left ovary decided to grow a mucinous cystadenoma, and I did want it taken out before it got too big. So I had a laparoscopic cystectomy. Now, this is a picture of my pelvis. You're welcome. And after this surgery, laparoscopic, I felt great. I had zero pain after this surgery, which was in stark contrast to this leg surgeries I had turned into multiple leg surgeries I previously had, which hurt so much. So I felt great. I walked out of the hospital, same day discharge, and I was in Philadelphia. Again, I didn't have a car in Philadelphia, so I was looking for a cab to go home. Could not find a cab. So I proceeded to walk a mile immediately post-op to find a cab, got home, did fine. Absolutely no idea what my post-op restrictions said, and those I could not find in the MyChart. But I did go back to medical school about 2 days later and just lived my life. Now, the next time I had surgery was here. A lot of you were involved. I had a C-section. This surgery was also very painful. And I was able to find my post-op activity restrictions here. So it said, gradually increase your activities. Be sure to get some low-impact exercise every day. That's easy when you're going to the NICU every day. No driving for 2 weeks or while taking narcotic pain medicine, and don't lift anything heavier than your baby. And then as you start lifting, don't lift anything more than 20 pounds for 6 weeks. So I can tell you I did not read these after surgery. I just told my husband I couldn't lift anything for 6 weeks because my toddler was getting heavy and I was in pain and I didn't feel like it. So that's what I told him. Turned out that's similar to what it said. So why do I tell these personal stories? Not just to show you pictures of my pelvis, but hopefully to show some of that patient perspective, that what we do, depends a lot on how we feel after surgery, no matter who we are. Also, hopefully to encourage you to share with me when I ask you some questions during this talk. So what do our discharge instructions say here at UW? Well, I through the Mariner and UW Epics to find all the discharge instructions I could from the different services. So if these are not the most up-to-date, I'm sorry, but this is what I found. And I'll show you what our presumably surgeons are doing. So starting with the ASOG group, doing a laparoscopy, this is with no hysterectomy, so just a straight laparoscopy. They say nothing in the vagina for 2 weeks. It's okay to walk up to 3 miles a day. Okay to go up and down stairs in your home. Not sure if you're allowed to go up and down stairs elsewhere. Okay to shower. You can let water and soap run over incision. Pat dry, do not rub. No submersion. And no driving while taking narcotic pain medicine or until you feel comfortable. So that's the starting point. Let's then go into what ASOG says if you have a laparoscopic surgery with a hysterectomy. So how does this change? Well, now we say nothing in the vagina for 8 weeks, and this may be extended further. So if you remember, for straight laparoscopy, no hyst, pelvic rest was 2 weeks. So now we have a cuff. This is presumably the reason why we're extending the pelvic rest. Do not lift anything more than 15 pounds for 6 weeks. So there is something, and remember, there was no lifting restriction for the straight laparoscopy. So there's something about taking a uterus out that changes the surgery in such a way that you can't lift for 6 weeks. Now, I'm going to start asking for some opinions. Someone from ASOG who does hysterectomies, is it, yes, somebody from ASOG who does hysterectomies? India. What about that hysterectomy makes you not able to lift 15 pounds for 6 weeks?
What kind?
Why? What about the hysterectomy?
I was always told when I trained that you don't want anyone to increase their intra-abdominal pressure to potentially disturb the cuff that you just repaired.
Okay, so for people online, we don't want to increase intra-abdominal pressure so much to potentially disturb the cuff. I think that's pretty much the common wisdom that gets passed down. We're going to examine that. It's okay to walk 3 miles a day. That's the same. It's okay to go up and down stairs again in your home. The showering is the same, and the submersion is now for 6 weeks. Remember, for straight laparoscopy, it was 2 weeks. So again, there's something about having a cuff that makes you not able to get in water for 4 additional weeks. We'll get back into that. And then the driving is the same instruction. All right, so I found some different instructions from the MIGS group, and I don't see them here, so I can't pick on them. But they say no, this is for straight laparoscopy again, no hysterectomy, no strenuous physical activities, and very specific here, no pushing, squatting, pulling for 2 to 4 weeks. Now remember, our ASOG folks had no lifting restrictions for straight laparoscopy. So there's something about doing an endometriosis excision, for example, that makes you not able to lift. Now I'll pick on a resident, any resident who's been in a MIGS case. What do you think is different about this case that makes you not able to lift? I'm seeing a lot of So we don't know. We don't really know. Okay. And getting more specific, no lifting more than 10 pounds for 2 weeks, followed by no lifting more than 15 pounds for an additional 2 weeks. What is that based on? You may climb stairs with caution, you may shower immediately, and then it goes on to say you actually should be active. So we should be active, but not too active. And it gets a little confusing. It goes on to say If you have exercises you feel it's important to do after surgery, you must discuss these with your surgeon. If you're not sure, don't do it. I imagine this probably came from some specific experiences of patients doing some interesting exercises. And we encourage walking. You may walk up to 3 miles a day. Oh, now we have a qualifier on a flat surface. So what is it about going up or going down that's going to increase your risk after surgery? Do we have any ideas? Okay, not sure. Ask others to help with chores or errands. That's always a good idea. And then we go on. Nothing in the vagina for 2 weeks. That's the same. No swimming. And it goes on to say you might not feel like driving for 1 to 2 weeks. You know, potentially, so patients don't feel bad if they don't feel up to it for a couple weeks. But that is pretty specific there. Now, for MIGS, if they add a hysterectomy on, the no strenuous exercise goes up to 6 weeks. So it was 2 to 4 weeks for straight laparoscopy. Again, something about the hysterectomy is increasing the time that we can't do strenuous exercise. The lifting is the same, climbing stairs is the same, showering, and again, be active but not too active. Same thing about exercise, walking, and asking others to help with chores. But now our pelvic rest goes up to 8 weeks. Again, ASOG had said 6 to 8 weeks. This is 8 weeks. We're seeing the theme of variation here, and that's going to come up again and again. Now we have no swimming for 6 weeks, and specifically no bathtubs for 6 weeks. And ASOG had, or the MIGS had said 2 weeks for laparoscopy without hysterectomy. So again, something changes about having a cuff and your ability to go in water. The driving is the same. Okay, now getting into our maximally invasive surgeries, C-sections. What are the activity restrictions that I found? Well, it's okay if you're not as active before you have a baby, or yeah, for your surgery. You should avoid starting any strenuous activity or exercise until your 6-week postpartum exam. Now that might have some more to do with postpartum physiology than surgery. Not sure. Do not lift anything heavier than your baby for the first 6 weeks. Now this one is my favorite because this is a picture of a baby I had, a mini baby who is 4 pounds. So I presumably could not lift anything more than 4 pounds for 6 weeks. And that's barely anything. Yeah, that's nothing. But what about the mom who had a 12-pound, 10-ounce baby? Is she stronger than me? Does she have better fascia than me? Why can she lift more than I can? So this brings up a lot of questions here. Namely the question, does every baby make the same face when you hold them up against the cover? Probably yes. They're angry. Then it goes on, again, you can go up and down stairs. It's as the laparoscopies. And no submersion for 6 weeks again. So remember, it was no submersion for 2 weeks when we had a laparoscopy. So there's something about a bigger incision that makes it take longer before you could get in water. Same skin, same incision, same probably suturing, but something about a bigger incision makes you not able to go in water for longer. Anyone who does C-sections want to give me a rationale on this one? I hear nothing. Okay, I hear nothing. All right, so we go on to say no driving, same, no sex for 6 weeks. That's a little more serious about getting pregnant after having a baby. Do not put anything in the vagina. Now going on to what our gyn-oncs say. So this is what I found from the UW Epic. So same surgery, just a straight laparoscopy as our ASOG folks were doing and our MIGS. We say no vaginal insertions for 2 weeks. Avoid lifting greater than 10 to 15 pounds for 2 weeks. Remember, ASOG had no lifting restrictions for a laparoscopy. So something about having cancer makes you not able to lift for 2 weeks if you have a laparoscopy. Now, I think the only gyn-onc that is here is Dr. Hartenbach.
I'm just scared to show.
Why can't they lift for 2 weeks?
So these are incongruent and they don't make much sense. And I've had a laparoscopy, so I have some opinions on what you can do after.
Okay, yeah. And we can't shower or bathe until after our post-op visit, so that might be a while. Or sorry, not shower, you can shower, you can't bathe or submerge until after your post-op visit. What about if we add a hysterectomy onto that surgery? Well, nothing in the vagina for 6 to 8 weeks, pretty similar to the other ones. Now, no lifting for 6 to 8 weeks. Again, no bathing or submersion until after you see your surgeon. And then I found some other stuff from Gynonc. Don't do strenuous exercise that uses your belly muscles, specifically yoga, biking, carrying laundry baskets, grocery bags, vacuums. That's a lot of normal activities that people do that they are then not allowed to do after surgery. And, you know, we can theoretically think about what we're concerned about with our belly muscles, but we're going to examine that, whether that really matters.
This one I'm gonna advocate for because the laparotomies and the co-surgeries that are done with hysterectomy in the oncology world.
Yes, yes, and we do get into some general surgery stuff in this talk too, some of those surgeries that are done together. And so some of the Gynoncs I think are saying no lifting more than 10 pounds for 4 weeks, again, some variation within the group. And then the driving is the same. Now, what do we say in Urogyn? We say the most important thing is to use common sense in linear activities. If it hurts, don't do it. Don't do anything to the point of exhaustion. And you should be up and moving after the surgery. Gradually increase your activity as tolerated. There are no defined weightlifting restrictions. You're allowed to basically do whatever you want as tolerated. Listen to your body. If an activity causes fatigue or pain, take a break. Whoa, are the Urogyns crazy? Maybe, but I think you'll start to understand as we go through this talk of why we might be giving some different post-op instructions to our patients. And we're not that crazy. We say the same thing about driving, basically the same thing about showering and bathing, but we do differ on this within our group. So I tell patients they can get in water a week after surgery. So am I crazy? We will find out. Nothing in the vagina until cleared by your surgeon. Again, we vary a little bit on when we let people have intercourse after surgery, but it's okay to use vaginal estrogen or dilator therapy if you've been instructed to do so. So this is where, you know, why can you put something in your vagina but not another thing? It's not all making sense, but this is what we say. So why do we limit patients' post-op activities? You know, a big concern is hernia, that we're worried about patients getting a hernia. But is hernia a common occurrence after surgery that we do? No. So after C-section, which is one of the biggest incisions that we make, the hernia risk is very low. So there's a systematic review of over 275,000 women that reported hernia rates of 0 to 5.6%, and that was over 6 months to 10 years in the variety of studies. So that's very low. And when you look at laparoscopic surgery and looking at port site hernias, there was a recent meta-analysis of over 70,000 patients that found a pooled incidence of 0.29% for a port site hernia. So very, very low. And when you're looking at biomechanically, there actually was a German systematic review that looked at biomechanics of the abdominal wall and found full normal resistance to exertional stress by 30 days after an uncomplicated laparotomy healing. So full strength, 30 days. So, you know, raises the question of why should we be concerned after 30 days. And we also worry about infection, of course. This is why probably we are limiting submersion in water because we're worried about transmitting an infection. We'll get into that. And then we're worried about cuff dehiscence. And that's, you know, what India had mentioned of why we limit some things. And of course, why we limit vaginal insertions after surgery, because we know intercourse is the most likely event to cause a cuff dehiscence. But when big meta-analyses have been done of all of these cases of cuff dehiscence, there really is no clear pattern to the timing of when these occur. And there have been absolutely no studies done on comparing an early versus late resumption of intercourse to give us any data. So we really don't know. But kind of looking at all the data, you can presume that because it is so varied, it has more to do with patient factors, their tissue health, nutrition status, medications they're taking, and the way that you potentially close the cuff, giving you a risk for dehiscence rather than something the patient is doing themselves. Okay, so what studies have been done to actually look at these activity restrictions? There have been some. So this was the first one that I found in 2008. This was done by a group of Eurogynes, and they looked at intra-abdominal pressure with women doing different lifting activities. And these were 41 women who were getting urodynamic testing. So in urodynamic testing, we do have pressure catheters in that measure the abdominal pressure. So this was a good way to do this study. And they had them performing 4 different lifting maneuvers, lifting different amounts of weight, and then analyze how much intra-abdominal pressure it is generating so that we have some data. And then they wanted to kind of apply this to what we could do for post-operative restrictions. So this is where I'm going to ask for a volunteer to demo so we can see what's going on here. Who wants to move their body? Oh, yeah, Kitty, thank you. Okay, okay, there's a bucket over there that you can pick up the bucket. Full of office supplies that I will return to McConnell Hall. So the first maneuver we're going to demo is squatting. So you are going to, hold your bucket. You're going to squat down and then lift it up, and you keep it at xiphoid height is what they did. Yep. And then stand up with your bucket. Okay. And you're going to be thinking about how much pressure you're generating and give a guess. Okay. Maneuver B was, you're going to do that maneuver again, but you're going to brace yourself on the table with a hand and see if that makes a difference. Makes a difference. Okay. Now you're going to put the bucket on the table and lift the bucket up to chest height. Less or more than less. Okay. Now you're just going to I'm going to hand you the bucket. Okay. How'd that feel? Less pressure. Okay. Thank you, Candy. So that's how they did the study, except with, catheters in to measure the pressure. And they found some interesting findings. So this graph on the x-axis shows in each sort of section which maneuver they were doing, and then each color bar shows the amount of weight that was in the bucket. And then on the y-axis is the mean intra-abdominal pressure increase. They had them do each maneuver multiple times, and they averaged the amount of intra-abdominal pressure here. So what you can see is that even just squatting with 0 weight, so that is the far left white bar over here, generates more intra-abdominal pressure than receiving a 15 kilogram weight, which 15 kilograms is a bit heavy. And then they interestingly found that doing the assist with the hand on the table did not significantly reduce the amount of intra-abdominal pressure generated, despite their hypothesis that it would. But I think overall what this shows is saying lifting, don't lift is a little bit too vague if we're really concerned about intra-abdominal pressure generation, because the way you lift really matters here. Oh, somebody's talking. So this is starting to give us some data. Now, the next article I found that was very interesting is from 2009, so more than 15 years ago. There was this review article done in the Green Journal called Building the Evidence Base for Post-Op and Postpartum Advice. And they were able to look at median intra-abdominal pressures among 30 women during various activities to start really comparing how much pressure each of these things generate, again, if we're really worried about intra-abdominal pressure. So this is where I would like another volunteer to come demo some of these activities. Who else wants to move their body? Maybe Kitty has to pick a friend.
Let's try to figure out what rating.
Okay, Raven happening. You know, when I imagined this in my head, I imagined Raven doing this. You can both do it. Raven, not Reagan.
Like some of the third.
No, Regan and Raven. Yeah, it sounds very similar. Let's have both. So, first is lifting about 8 pounds, which is pretty much what we tell our patients, don't lift anything heavier than a gallon of milk, right? That's about 8 pounds. And I have a gallon over there of iced tea because milk is gross. So why don't you lift it and think about how much pressure that's generating. You have Reagan lift it too. And then we're gonna have one of you sit down on the chair. You can put the gallon down. Well, you can take it back to the rest of the room, but yeah. All right, stand up from the chair. Did you feel some pressure there? Not really. Okay. You can have Raven kind of repeat. We're gonna climb up some steps. So we climb a few steps and walk back down. Feel some pressure? No, we're not feeling anything. We only felt pressure from the lifting.
Not even like really from.
Not even really. Okay. Do a small cough.
More pressure.
More pressure. I won't make you Valsalva while you're out here, but do some jumping jacks. And lastly, can cover your mouth. Okay. What did we think?
Pressure from the jumping jacks.
Definitely pressure from the jumping jacks. Yeah, we did our Valsalva. Okay. Yeah. Great. Okay. Thank you. Raven and Reagan. Yay. Okay. So yes, they had patients do or subjects do all of these different activities and measured intra-abdominal pressure. And this is the graph that they came up with, that on the x-axis is the amount of intra-abdominal pressure generated in centimeters of water. And doing that lifting of the 8 pounds is what we usually restrict our patients to, really doesn't generate that much pressure over baseline, presumably because most people are using their arm strength to do that. As I know our strong residents were. But even very simple things that we do every day, like standing from a chair, climbing steps, are going to generate more intra-abdominal pressure than that. We cannot limit those activities. Look how high Valsalva is. We want our patients to Valsalva. We ask them all the time if they're pooping after surgery. So that generates much more pressure. And then a forceful cough, again, we can't stop patients from coughing. Sometimes we even tell them to cough to prevent a pneumonia after a big surgery. So if we're really worried about intra-abdominal pressure, we need to rethink if these restrictions are really important. Another interesting finding from this review article, they looked at an animal study that looked at the burst strength of open and laparoscopic hernia repairs. They looked right away and at 6 weeks after repair, and found the burst strengths for the repairs were over 250 milligrams of mercury. You can see that's much higher than anything on this graph. So it would take a much, much higher pressure than any normal activities, including lifting 35 pounds from the floor to burst open an incision. And the authors of this article essentially recommended some very specific recommendations on what we should do after surgery based on all of their findings from the review. Now remember, this was more than 15 years ago, so a lot of this has not really been adopted, and it was in the Green Journal. So what they said for lifting is patients should continue lifting patterns as they were before surgery. They do need adequate pain regimen, and we should keep our pre and post procedure recommendations consistent. So we should not be confusing the patients. For exercise, they again say they need appropriate pain regimen. They can resume their pre-procedure exercise level. So no restrictions on exercise. Do need to exercise or tailor an exercise program for postpartum women. And again, keep our recommendations consistent. For intercourse, this is what I think is the most radical here, is that women and their partners should make the decision to resume intercourse mutually. They should use lubricants and sexual positions permitting the woman to control the depth of penetration, and use contraception after childbirth, and again, keep your recommendations consistent. So that has no restrictions on when people should resume intercourse. And I don't know anyone who has adopted that at this point. This is an area that would be very interesting to study, but has not been studied. Okay, so moving forward in time, jumping to 2020 is when I think this area of interest started really gaining and a lot of articles started coming out. So this one here is from another group of urogynes who did a survey at one of the national conferences that had minimally invasive gyne surgeons and urogynes primarily. And they surveyed the surgeons as to what the maximum post-op weightlifting restrictions that they gave their patients were after surgery. So this graph here on the x-axis shows how many pounds they were restricting the patients to. Y-axis is the percentage of the respondents to the survey who chose that number. Every different bar is a different type of surgery. You can see here there's not a lot of variation between the surgeries, but there's a lot of variation between the surgeons. And the most common weightlifting restriction was no more than 5 to 10 pounds here. So this, again, just shows the variety in what patients are, or what surgeons are doing. They also asked here about how many weeks they restricted patients' activities for, and this included return to work. So they asked about return to sedentary work and return to manual work. How many weeks do you tell your patients to wait? And you can see here, again, a lot of variation. That's kind of the moral of the story here. Is a lot of variation in what people were doing. And interestingly, they found that although years in practice was not associated with recommendations regarding return to sedentary work, respondents who were in practice less than or equal to 10 years recommended waiting significantly longer before returning to manual work. And compared with male respondents, female respondents, so surgeons, were significantly more likely to recommend prolonged restrictions for manual work. So we have variation now in surgeon time out of training and surgeon gender as to what they're doing. So again, you can see the theme of it's not necessarily about the patient or the surgery, but a little more about the surgeon. All right, now our general surgery friends did a very similar study in the same year, also in 2020. They did a survey of surgeons in the American College of Surgeons, asking them really similar questions. So this graph here shows how many weeks they're doing activity restrictions for. The blue lines are open surgery, the orange lines are minimally invasive surgery, and the y-axis is the percentage of respondents who chose that answer. So you can see here the most common restricted time was 2 weeks for minimally invasive surgery and 6 weeks for open surgery. And there's a lot of variation. So the general surgeons are just like us. A lot of variation here. Now we are getting into studies that were done actually looking at restricted versus liberal post-op activity. This is where it gets really interesting. So does this matter? This study was published in 2021, again by a group of urogynes. So starting to see whether urogynes might be doing things differently than everybody else. A lot of this work was done in our field and has been really hot topics at our conferences for the last several years, but might have not made it out of our world as much. So this was a very nice study that was a randomized multi-center double masked clinical trial. It enrolled women undergoing surgery for prolapse, and they were either randomized to liberal restrictions, which had no activity restrictions, or restricted group. So they were restricted on heavy lifting or high impact activity for 3 months. Then this chart shows the outcomes at 1 year. So they were looking at patient satisfaction. So how satisfied are you with the results of your prolapse surgery, and on recurrence of prolapse. So you can imagine urogynes are particularly sensitive to increases in intra-abdominal pressure because we know that repetitive increases in intra-abdominal pressure increase risk for prolapse over time and other pelvic floor disorders. But the question was, does it matter in the post-op period specifically? So what they found here, and I guess before I go into what they found, this chart shows the different surgeries that were included in this trial. So you can see it is varied. So there's minimally invasive sacrocolpopexy here. So we can liken that to any of our laparoscopy procedures without a hysterectomy. There were vaginal procedures in here, and then a lot of them, over half, had a concomitant hysterectomy. So we can also apply this to patients having hysterectomy with their surgery. And what they found is there was no difference in satisfaction or return of prolapse in a year between the two groups. So it did not matter whether they told them restricted for 3 months or no restrictions at all. There were no complications differences either. So everyone essentially healed about the same. Then also in 2021, there was a systematic review published looking at all the literature on post-op work and activity restrictions after abdominal surgery to kind of get a handle on this. And interestingly, this included 2 separate reviews. So they did one on basic science literature on fascial healing, and then the other one clinical on surgery healing. And from the basic science literature, they found for healing of the rectus sheath, the time to 50% strength, and this is in animal studies, occurred somewhere between day 3 to 13 in different types of animals, so that's pretty early. And the final strength of the wounds was a bit varied, but it does show like fairly quick healing of the fascia in animal studies. And another basic science fact they found was abdominal wall loading and mechanical stress, which do occur through physical activity, seem to be important factors in the stimulation of fibroblasts to produce collagen. So does activity actually stimulate healing is the next question. And in all of the studies they reviewed, none of them reported an association between activity and complications such as incisional hernia. So that is not proven. Another study they talked about in the clinical part was a study using the Delphi method and an expert panel of 13 practitioners to try to come up with convalescence recommendations following uncomplicated abdominal surgery. And they talked about different activities, different weights. The group deemed that these were safe between 1 and 6 weeks. Again, variation here. Just getting experts together, and they advise resumption of an average job at 2 weeks, but 6 weeks if it's longer convalescence if it's colectomy. So again, getting into things our general surgery friends do, and potentially our gynec patients are having bowel surgery. 6 weeks for minimally invasive, 8 weeks for open. So this was, getting experts together, and in a Delphi study, they try to get consensus at each round. But they noted a lack of consensus on round 3 of 4 for half of the activities. So it was really hard to get experts to agree on this. Part of the review that was looking at return to work, I thought was very interesting as well, that they found factors associated with longer recovery periods included low job satisfaction and younger age. So maybe they don't want to go back to their job. Higher monthly income and freelance work were associated with shorter recovery periods. And many of these studies that they looked at noted patient work status and decision to return to work were highly influenced by their own sick leave policies at work and the instructions given by providers, rather than how the patient feels or their physical abilities after surgery. So the last article I'm going to talk about in terms of activity restrictions is a newer one from 2023 that was building on the work of that other study that randomized the patients to restricted or non-restricted. This was also done by a group of urogynes, and it was published in JAMA Surgery. They made this really beautiful visual abstract that I included here, and I think that really helps sum up the study nicely. But this included a group of 107 women. They all had prolapse, so they had at least a stage 2 prolapse, and they were undergoing an apical prolapse surgery. So those are really our more invasive surgeries. Mean age about 62. They did randomize them to either standard post-op activity, which for them was no lifting over 10 pounds for 6 weeks, return to work at 2 weeks for sedentary work, 6 weeks for manual work. That's pretty typical restrictions. Or the expedited group, which had no restrictions. They could resume their activities and their work as soon as they felt able. They made sure to include a physically active population at baseline, so that this would be more applicable to physically active patients. So they did use a couple of screener questions to enroll in the surgery to make sure that patients did not have difficulty walking a couple blocks or upstairs. And they found no difference in what they measured was time to 90% recovery. So this is subjective evaluation from the patients of when they felt 90% recovered back to their baseline activity level. So both groups took a median of 9 days to return to 90% of their baseline activity levels. That is pretty quick. They also, in this study, used accelerometers. So they actually measured how much people were moving, and so that they could kind of verify that what patients were reporting was fairly true. And the mean return to work was the same in both groups as well. Mean return to work was around a month. And there were no differences in post-op complications. So further supporting the safety of.
It is interesting.
Was that a question? Maybe not. Of unrestricted post-op activity. Okay, so the last topic I'm going to talk about before we can have some discussion is the topic of submersion. So this I find very interesting, very, very low data zone. So this is a Cochrane review that was looking at early versus late post-op bathing or showering to prevent wound complications, and they found exactly one trial to include in this Cochrane review with a high risk of bias. So this is like the most terrible evidence that exists. But this was the one study they found was a study of patients in the primary care setting who had simple wounds that were sutured because they were having an excision of the skin, and they randomized them to either remove the dressings and be able to bathe and shower at 12 hours or at 48 hours. And they found no difference in surgical site infection, which is, what we're usually worried about when we're talking about submersion. So this is it. This is the only thing that exists. Maybe this study could be done in a much larger setting of surgical wounds, but it has not been done yet. And, when you look at basic science, a typical surgical wound closed by primary intention does achieve surface epithelial closure within 24 to 48 hours. So by 48 hours, the surface epithelium should be closed, pending any wound complications. In a normal setting, it should be closed by 48 hours. So I dug deep into the literature on this to try to find any examples of wound complications from submersion. And there's one case report, one case in all the literature that I have searched for this for years because I was so interested in this. In 1986 in Canada, there were a group of hospital staff and patients using a physiotherapy swimming pool that had a Pseudomonas folliculitis outbreak among the PT practitioners. And there was one patient who had a surgical wound who got a Pseudomonas infection of the wound. They isolated the same Pseudomonas from the wound and the water and the folliculitis, so they confirmed the link. But this is one case in, forever of literature of a surgical wound getting infected by water. So should we really be so worried about our patients getting in water? Is a question. Now it's our time to question, ponder, discuss. Do we really have a foundation for our post-op activity restrictions? Are we potentially harming people by our post-op activity restrictions? Does anyone want to change their restrictions or question anything that I've talked about today?
I'll just jump in and say, we do a lot of things by sort of tradition or what we were taught. When I was in training, we didn't let people leave the hospital until they had a wound, right? We also kept them NPO until they passed gas, all kinds of things. So I really appreciate your looking at literature, talking about it, bringing all these things up. And I think one of the most important things you've said is the patient experience, right? Because, you categorize all these different surgeries, but we all know they are somewhat different and they're interacting different with the patient. But overall, you make a good argument that we can be more liberal for sure. And having had 3 gyne surgeries in my life, my activity was much more flexive of how I was experiencing the pain and experiencing my recovery than it was of anything that was written on a piece of paper.
Yeah.
But I don't know. It's interesting. It's interesting.
it would be interesting to do those restricted versus non-restricted studies in gynonc patients, because that is a different patient population.
Yeah. But right now, we're doing like 75-80%, minimally invasive surgery.
Mhm.
And I think you make a good case that the minimally invasive surgery, no matter who's doing it, we're talking about small incisions and, so that, I think I've said enough, but the getting in the water, like when you have an incision, you don't really feel like getting in the water that quickly, frankly, whether it's a pool or a lake.
Yeah. Yeah, so that's why a lot of this is like, we in NeuroGuide, we tell our patients, when you feel comfortable doing something, then you do it. And we say, if it hurts, back off, don't do it.
Right. And how much water actually gets in your vagina when you're like. The top of their vagina when they're in a pool. I
don't think it does.
I'm gonna vote that it doesn't.
Yeah. Raven, yeah.
Thanks for the presentation. I think it's helpful to have like data to back up kind of like, or like at least make us question why we do some of the things that we do. And I think a lot of it also comes from like this place of like fear, like seeing like vaginal cuff to hiss. Like it's obviously not great when you just see bottles hanging out of people's bodies. And like I've seen people like do like restrictions from like as little as like 6 weeks to like as many as like 12 weeks. And so it is kind of like this presentation I feel like makes you think like, am I doing this because like I'm trying to make myself feel better based off like the one person that had like a cuff to his in this like situation versus like, am I actually like doing like what's best for like my patients as a whole? And so it's helpful to have like data to like back up making the suggestions that we're making.
I've been a fan of liberalizing these sorts of things for a while. I think, I've done the whole it hurts, don't do it sort of idea. And, I tell people they can drive their car when they can slam on the brakes. And, because I looked this up once and there's just not a lot of gray area. So anyways, but yeah, I mean, yeah, I think we probably should. I think people getting up on their feet and moving is just the best thing. And then, what that looks like is going to be visualized probably.
There's a couple things popped up on the text, on the chat box.
Oh, a couple things on the chat. Oh, up here, okay. Do you counsel people how much time to request out from work if we can't really tell when they'll personally feel ready? They need to anticipate to tell their employer. Always easier to overestimate. Yeah, I agree with the overestimation thing. That's what I tell patients is, I say usually people will take a month off, but if you feel ready to go back earlier, I'll sign whatever you need me to sign to get you back earlier. If that works better for your life and your financials and everything. So I agree with that return to work sentiment. A lot to do with patients, financial needs. Yeah, Bob.
I just have two comments. So
Yeah.
one is coming from the East Coast, a lot of plastic surgeons will actually tell their abdominoplasties to swim in the ocean, and the Atlantic is gross. But they actually tell them after 3 days, actually they want them in the ocean because the salt water is good and like fresh water is good. And like we're talking about the biggest incisions you could possibly get. Second comment is just remember load bearing, right? The vaginal apex never bears load unless you have a vault eversion. It's the pelvic floor in the anterior vagina. So the cup never bears load. Like, so you're not going to hiss lifting something. It just doesn't happen. So.
Good comment. And then of interest about the water and peds, my son had hernia surgery and is a swimmer and it was summer. They advised him just 1 week and then he could swim in a lake and also a pool. He did fine. And yeah, that's what I tell my patients. And I've been doing that for 6 years that I've been in practice is you can swim after a week. And I've never seen a wound infection from swimming. Again, not in the literature. So, and a lot of patients are delaying their surgeries because they don't want to have to abstain from lifting their kid or swimming or, playing pickleball. So we are potentially harming patients by deterring them away from surgery that would really improve their quality of life. Yeah, Abby.
Why a week?
Just because the skin should be starting to scar within 7 days. So that gives me some peace Yeah,
Right, but that's also like based on bias.
yeah,
Yeah.
uh-huh.
So I'm just like,
Yeah.
I mean, it's whether we like restrict liberally or conservatively, or it's all, you cannot guarantee if someone swims in Lake Wingrove versus a pool too,
Yes.
right? Like that's gonna determine.
Right, this one infection
So,
came from a
correct.
healthcare
So,
facility.
Yeah,
so-
I think for me, the most important, I mean, this is very validating and like what I usually tell patients, which is like, there's no good evidence for any of these instructions, but like, this is why they're given and this is why you'll see variation. And if I were you, this is what I would do, but
But I do think we have an opportunity to clean up some of our stuff things, because people do read that stuff and, you know, having done, I don't know, somewhere around 4,000 or 5,000 surgeries and had 3 of my own. I put this in kind of like 3 buckets, like the straight forward laparoscopy is kind of like the 1 to 2 weeks. I mean, I was doing major surgery 4 days later, like it, you know, and the you know, the fannies and the you know, minimally invasive hiss, like maybe 2 to 4 weeks, you know, with some limitations. And then really anything, you know, over 4 weeks really needs to be sort of the open midlines, the open large above the umbilicus midlines. I mean, even the low midlines, you know, like I had my C-section, you know, I took my oral bores 3 weeks later, you know, like it's, so, but I think we have to be sort of careful what we put on all the sheets, and I think it should make sense. And this is just a great presentation. It gives people things to think about. But that sort of those dehiscences, you know, they do seem to be anecdotally related to early intercourse. I just have to put out there, having taken care of a lot of them in my life.
Yeah,
I
maybe
mean,
that,
not a lot, but.
that study should be done. You know, that hasn't really been done.
Yeah. But you don't really want to randomize people to be like, you guys go have a bunch of intercourse, and you don't have the variable of the size of the part, the activities. I mean, it's like, it's a different situation.
That is true. You need a lot of variables.
A lot of stuff there.
Yeah, but like in my experience counseling the Euroguide patients the way we do with the liberal activity restrictions, they often, in my opinion, feel more comfortable having surgery, knowing that they're not restricted after. They're not as scared, because I feel like it scares people when they feel like, oh, I can't lift this. If I lift too much, I'm going to screw everything up. I'm going to end up back in the hospital. And it sort of decreases some of that anxiety to tell them, like, you're not going to ruin everything by, you know, gardening when you feel ready to garden. So, you know, we have to think about the patients.
But you guys do have the easiest recovery.
But we do it the same for our laparoscopic surgeries as well. For our laparoscopic robotic surgeries, we have the exact same liberal restrictions. Yeah.
I was wondering if you had any input or saw something in the literature about like PT or physical therapies input, or like especially with like pelvic floor therapists, like did they have any suggestions? Do they just follow what the surgeon recommends? Like, do they want, you know, movement earlier? Like, did you see anything about that or know anything about that?
Just that they were included in design of those studies, looking at the intra-abdominal pressure, that they were included in making sure those were safe exercises to do, you know, for the body, and that they would kind of mimic real life maneuvers of the body. That's all I really found. Thank you for